in the next hour and a half. So our kaupapa for today's webinar is culturally responsive health promotion approaches in Aotearoa, New Zealand. So before we get into it, grab your pens and papers, take some notes as fast as you can. Before we get into the first presenter, I would just formally like to thank you for joining us today. Also to our esteemed guest speakers who you get to listen to today, thank you very much for taking time out of your busy schedules to join us. That is Summer, Vishal and Sione. And also to the Health Promotion Forum team, kia ora Emma, Lavinia, Leanne and Sunila, the Dream Team. Just a bit of housekeeping for us today, whānau. Please keep your mic on mute if you can throughout the duration of the webinar. At the end though, we do like a bit of a full gallery open floor type thing. So then you can unmic and we can have a big kōrero with everyone. At the end also, please stick around. We're going to get a full whānau photo. So we will ask you to show us your beautiful face. And importantly too, so we do want you to have the opportunity to talk to our guest speakers. So in the chat's going to be firing away throughout the webinar. If you have any questions at any point, please put them in the chat and we can ask them on your behalf during question time. Just to let you know, this webinar is being recorded and you will have access to the recording if you are part of the people that paid for access, or later on it can be accessed via our YouTube channel. And lastly, Emma, the lovely Emma, who you all know, may also send out a little evaluation for us to do in the chat. So I'll let Emma take care of that. Also, we have a couple of pānui. So we have a couple of kaupapa through Health Promotion Forum going. So the first one is the International Network of Indigenous Health Promotion Professionals. So if you are Indigenous and you are a health promoter, or you do health promotion mahi, doesn't necessarily have to be in your job title, and you want to be part of this ropu, just let me know. I'm going to put all this information in the chat. And secondly is our National Accreditation Framework, which Sione might touch on, but I'll also put that in the chat as well. Anyway, we'll go back to our kaupapa for today. So culturally responsive health promotion approaches in Aotearoa, New Zealand. So what does culturally responsive mean? So technically it's the understanding, it's appropriately including and appropriately responding to the combination of cultural variables and range of diverse dimensions that a person or people bring to their interaction. So in health promotion practice, what does that mean, Miriana? So how can we as health promotion professionals and practitioners be understanding, be inclusive, and respond to people's cultural variables to best increase their quality and access to health, whilst maintaining their rangatiratanga and mana motu hake as people as well. So we have three very expert guests with us today who will explain how we can do this. And they'll be looking at the Māori community, the Asian community, and the Pacifica community. They may also branch out during their kōrero and include other groups as well. I do want to acknowledge today that there are also other diverse communities and dimensions that people bring to the table, so such as age, gender, sexual orientation, all those things. Now, I do want to acknowledge we won't be focusing on that today, but that's definitely something we can discuss in the future. So I just wanted to point that out. All right. So in the chat, I'm going to show up our format for the webinar today. But enough from Miriana. That's enough from me. We're going to go straight into our first guest speaker. So, speaker number one, he puti ia no Ngāpuhi me te Mahuruhere. Summer Hawke is the Chief Advisor for the National Public Health Service for Health Promotion with Te Whatu Ora. As Chief Advisor, she provides tiriti-led leadership, analysis and advice to support the achievement of Pai Ora goals. She offers technical advice, leadership and senior expertise to Te Whatu Ora and helps shape their health promotion solutions. She lives in Christchurch with her partner and her large whānau. She has a strong record in achieving equity, leading to her being recognised with a few accolades, including Te Tohu Amorangi, Te Kawamata Aho Public Service Commissioner's Commendation for Excellence Award. Nō reira, tēnā koe, Sama.
E mihi ana kia koe te katoa ko hui hui mai nei. E tika ana ka mihi, me mihi kia koe e te tuahine nau I tō mai te wairua o ngā atua ki tō tātou hui. Nau anō e tuku kupu hakatau kia mātou kua hui hui mai nei I te rā nei. Nō reira, tēnā koe e rere ana ngā mihi aroha kia koe kua tūtaki ki e rā o ngā tikanga koe mā koroma. Nau te karanga hoki, kia tai mai tēnei, ki te kōrero tahi kia kouta katoa. Nō reira, kia tātou kua hui hui mai nei, ko Sama Hawke tōku ingoa, he moko puna ahau no te mā hure hure, tēnei ahau e mihi ana kia kouta katoa. Kia ora everybody, just a big shout out to Miriana for opening our hui and also for inviting me along to come and hang out with you all and to share some of the beauty of South Auckland. I've chosen that community to speak to today. So I'm going to go really quickly over some of the initiatives, the health promotion initiatives. So I'm really happy for anyone to reach out to talk about the detail or give some further detail around some of the mahi that we've done together with our communities in South Auckland later over email or something. Kia ora hoa, I asked for a driver today. So I've organised my presentation to describe what we are calling a whole of system health promotion approach. And then, as I said, I chose a case study that shows how powerful service reorientating and community action are, which are two of my most favourite functions within health promotion. And I just want to acknowledge my colleague Kitty McQuilkin. I'm sharing a lot of the work that we led together. And we use this whakatauki to show the importance of the near and far work that has to be considered when serving our communities. Thank you, Ehua. So we're a new directorate within the National Public Health Service, and we're just refining what a whole of system comprehensive health promotion approach is. You know, drawing on some of the, we thought to start describing our approach, we want to strip back to the basics and really look at those core foundations that set our mahi in terms of health promotion. So looking at the Ottawa Charter and including healthy public policy, the importance of our environments, community action, as I said, and reorientating health service. Reorienting health service. In my observation, being new to the National Public Health Service, and this is actually my first official health promotion role, I've always used it in my population health mahi. I think the reorienting health services has been lost in terms of sometimes our whole of health promotion approach. And I think that is the most important part when considering and applying health promotion. And I think, and I've bolded those two because those are the two I'm really going to target and draw into today's presentation. And what I kind of use is, you know, we don't want to rely on our communities to build trust and give those important health promotion messages and health messages and drive them to a service if it's going to be crap, if it's not going to be accessible, and if it's not going to be high quality, and if our whānau are not going to be treated well there. So I think reorienting health services is a really important part to make sure this is the kind of call for action end that we talk about in health promotion. So I've bolded that too, because that's what we're going to hone in on today. Kia ora e hoa. I mean, this is how we're describing it at the moment, because we do get asked about, well, what is the whole of system? And I think, you know, we really want to be influential and position ourselves to influence the whole of system to be valuing health promotion in our mahi, and not just leaving it for health promoters alone, for the community alone, for communications and marketing. There is a place for the whole of system, especially when we think about behavioural support techniques and behavioural change techniques. I think every health conversation, there's an opportunity for that to be included there. And so we talk about it as it works across a continuum, influencing policy, as we spoke about earlier, raising awareness, supporting community action, including building capacity and capability within our communities. And we will always apply equity and te tiriti o waitangi in our mahi, and using a population approach, a population health approach, really understanding the needs of our population by community level. And this is just a diagram. And again, we are refining this as a directorate. It's very new, and we're building our language and our terminology and testing it with various partners. My colleagues have done a roadshow across the motu to get feedback from our communities and from our stakeholders on our operations model. And this has helped shape this early work. One of my observations, some of the behaviour of our colleagues in the health sector is that they have always seen health promotion as a national campaign and a billboard and pamphlets. Me pono aku kōrero. You know, that's how we've kind of observed is the thinking around what health promotion is. And so we really want to set this health promotion approach to say that social marketing, there is a place for that, and there is also a place for community action, including being influential in terms of policy, systems and environmental change. So I'm going to jump down now into the case study just so I can demonstrate around how we can apply a whole of system health promotion approach into our mahi. As you all may know, the COVID-19 response was led nationally. And in Auckland, we had the Northern Region Coordination Centre in place that covered all DHB catchment areas from Northland to counties. Not far into the COVID vaccination rollout, we saw the rates of uptake fall behind tremendously in counties. And I was asked to go and understand the vaccination program. And at the time, the intent was to pull out of the national and the regional program, as we were extremely unhappy with how counties were faring. On understanding the program, we saw that all the thinking and decisions were made nationally and regionally, very heavily prescribed from that level, and did not acknowledge our local population differences, needs and challenges. To be honest, and anyone that worked in any area of the COVID response will know this, we worked in a very reactive space. We inherited a program to manage and operationalise that we believed was not fit for purpose for our whānau in counties. There were countless times of high-risk situations, putting out fires and problem solving. We immediately identified inequities driven from different areas of the program, including the national booking system. People couldn't access or navigate the system, and appointments were getting taken and booked by other people, and at times by people outside of South Auckland. We pushed for shadow or protection settings in the booking system for Māori and Pacific, and prioritised engagement, health promotion over communications. We escalated the inequities of vaccination rate for people in South Auckland and for Māori overall as a risk on the risk register, which forced attention to our mahi. We set our understanding, our population framework, which became the secret weapon in advocating to reorganise a program and offering that was meaningful and relevant to South Auckland. I did have a table here to kind of demonstrate this framework, and I left it off by mistake. But what it is I'll talk very quickly to these terms, and they're really poorly languaged, but it's intended to use in the background. We'd never go out and talk to our communities and say, you guys are willing and able. But if you could imagine in a COVID context, willing and able, and we've applied this to other areas, childhood immunisations, it's a great segmentation piece to really think differently around the gaps in our service offerings, especially universal services, and when communicating or delivering campaigns to a whole of population. So in COVID, willing and able, we saw that as about 75% of the population, the biggest amount of the largest cohort. And I'd describe that as myself. I was able, I had a warranted car, I've got food on the table, I don't have to think about anything, and I knew the importance of going and get the injection. There are the willing and unable. So we saw this was our largest cohort in South Auckland. These are our whānau that are living with multiple stresses in survival mode homes. They've got other priorities and decisions to make. Often, sometimes what the kai is on the table. So these were whānau that really understood they were taking on the messages, and they knew it was important, but they just were not able to prioritise this. When we took COVID vaccinations to the street, and we'll talk about some of that mahi, they were rolling up their sleeves and they were taking the injection. We've got an unsure and uncertain cohort in COVID and in immunisations. We're really quick in health sector to label our whānau. We call them anti-vaxxers. We just give off labels. But once you take an understanding your population approach, we actually found this cohort had lots of mistrust and uncertainty of systems and of authority. The very systems that fail them and the very systems that often force them to rely on them. So when we went and talked to whānau, there wasn't that much mistrust in the vaccination. It was in the system and in authority. Then we have the strong decliners, and research says to leave these guys alone. It's unlikely that you'll change their mind. But in South Auckland, we found that this cohort often was so close to the unsure and uncertain, we made the distinct decision to make sure that everyone gets the same kōrero and the same offer. And this has become a really popular framework of how to think around segmentation and understanding populations, especially those ones that we underserve and we don't think of when we're putting together universal services and programs. Sorry, I'm just giving my stepson a kiss goodbye. Thank you. That's the next one. So essentially what that meant with doing all of that observation and that understanding and creating some thinking around where is the place for health promotion in this, we essentially flipped the way we offered COVID vaccinations in South Auckland, putting the mana and respect and enabling our own communities to drive the response in South Auckland, and through trusted relationships and their own known and reputable engagement strategies. Thanks. slide, please. Thank you. I mean, this is just some data to show the traction we started making for Māori in Counties Manukau once a new model of care. So this is where I'm talking about system reorienting now and the power of that. Once a new model of care and offering was organised for our communities. By the 1st of December, we were well on par with our Auckland Metro DHBs, so that's Auckland and Waitemata, and also to point out the absolute number difference. By 1st December, we had vaccinated nearly half the amount of Māori overall. What am I saying on this one? Kia ora. Next slide, please. This graph shows the same upwards trending for counties as the dose 1 slide. So these are dose 2s. Again, nearly hitting half of the Māori vaccinations for the whole Auckland metro area. Not only did this show that we were doing a lot of work, it also shows we had the most work to do. Next slide, please. So this is where we start talking about health promotion and the real importance of, so we understood that our model of care wasn't working for our whānau, so we changed that, and then we really relied on our communities to go out and use good best practice health promotion and reassuring kōrero to draw people in to get vaccinated. And here are just some of those campaigns and projects that we undertook, working in partnership with our community partners. So I'm really proud that I think this is like community action at its best. We worked mostly with Māori providers who have the reputation and trust within their communities, acknowledging that no one will love that community more than their very own leaders. Two of my favourites of the campaigns were Heroes in the Streets. I do have a video, we documented that to share if anyone is interested. And here's a photo of us outside one of our buses. You would have seen in the media, the Shot Cuz bus. And it was essentially, the Heroes in the Street program was essentially filling a bus with Māori doctors and leaders and hitting the streets, having conversations with the community and pulling them back to a vaccination base if whānau decided. So we all agreed that the first goal was to have really good quality kōrero and get information out into our communities, and the vaccination was bonus. This was one of the restriction times. I think we were working at level 3. So we had Aotearoa go ahead with a megaphone, warming up the streets that the bus was coming, and then the bus would arrive with a coffee truck and an ice cream truck. We called this street stimulation and street activation. We had people at times door knocking as well. And again, this was really targeting the willing and unable cohort and the unsure and uncertain cohort. All compliant with restriction settings, of course, because I think we were at level 3 or level 2. The second one quickly was street chats, where we developed a training tool and trained neighbours, communities and leaders. And what is COVID? What is the vaccination? And then best practice kind of health promotion techniques. So motivational interviewing, behavioural support and change techniques, and how to have values-based conversations, and then asked everyone to go and talk to their whānau and neighbours and communities from their pukus, because, you know, we could train anyone with those techniques, but to get that message from a trusted neighbour or a whānau or a peer is really quite different. Neighbours were given some pūtea to host street barbecues to draw their neighbours out to talk. And one case study we often quote or reference is Randwick Park. They had held 2 barbecues in a row. And then Manurewa Manurewa Marae went in on the 3rd weekend with their vaccinators and the bus, and they managed to vaccinate 2/3 of the Māori population in Randwick Park that day. Just watching my time, so I'll move a bit faster. If we could go to the next one. Okay, in the segmentation framework that I talked about earlier, again, we wanted to directly address some of the mistrust that whānau had. A lot of the time we were told it was not, as I said, the vaccination, but more so of authority and systems. And we really wanted to acknowledge that that's quite valid and real for whānau. So we put together a campaign using some very powerful images of really known Māori leaders. It was a powerful no speaking piece. And we had other people like Hone Harawira and Neida Glavish. So we knew that even our non-Māori people would look at that and know that these are really, you know, prominent leaders in our community. I'm happy to share that video if anyone is interested as well. Next, please. And despite all this work, we still came up around different problems. So next slide, please. I'll just keep going really quickly. This is Manurewa Marae and how I talked about the model of care change. So it's a case study to show that how we responded to that. You can see Manurewa had the highest number of Māori left to vaccinate. Throughout the whole response, Manurewa Marae were our test and learn champions that we would trial health promotion initiatives, community action here, and roll it out wider. They held fast to what they believed Manurewa as a hapuri were about, and they were our first provider to move to a hybrid model of offering and became accredited in outreach. We reduced the on-site booking so the team could go and work across the marae clinic and outreach on the streets. And then we moved to only have shadow bookings to enable walk-ins and to protect appointments for Māori and Pacific. Next slide, please. And this just shows this provider was always in the top 10 in the country for number of vaccinations and proportion. Here was the impact of the resets, quite a powerful graph. So this is what I'm talking about, the power of system reorienting. You can see that our Māori providers were mostly and with open arms and proud, looking after other ethnic groups and quite a high Asian population. And we made the change. You can see that after we made the change, you can see the drop for them and the switch up of Māori. And this was only in their clinic. So the drop of absolute numbers is from them also doing most of the work out on the streets. So we are calling this a system injustice and lazy planning. So for someone to think, so anyone, a funder and planner out there, you know, the intent, I never question the intent, but to think that you can set up a clinic in the marae and that gets our system a Māori tick, like, and that Māori will come, is quite lazy. And even worse, like that limited our highly experienced resource in looking after Māori because they were looking after others. And so I think this is also where the power of health promotion comes in, where we're making sure that the service is accessible, it's high quality, because when we do all our health promotion work in the communities, we want to push them to a service that can see them straight away and that will look after them really well. I'm nearly finished. I can go over the next couple of slides really quickly. Thank you, Ehua. This just quickly, when I was doing this mahi, I was the general manager of the population health team. My boss is a highly regarded public health physician. In fact, he was doing all the modeling for COVID, Dr. Gary Jackson, and he would do these graphs for me so I could forensically watch the data to make sure that our system, our service reorienting was working and that our health promotion was having an effect in the different communities. That's me. I think my last slide just acknowledges I will never, ever talk about this mahi without acknowledging these heroes here. Yeah, I think it was just such a, it just, you know, I'm still quite moved by the work and the power of, you know, the community. And if we we know that the solutions for Māori, for inequities, for many populations and many communities is closer to the community, the heart of the community. And I just really want to challenge our system to bring them along with us and acknowledge that they are part of the response and the solution. E mihi ana.
Oh, there we go. Oh, thank you, Summer. Wow, that was heaps to take in. Thank you for offering your slideshows too. I think some of us are really keen to have a look at those numbers and those stats and really break down what was happening and just see how that went for that particular area. First of all, I do have a question for you from the audience, but I just want to shout out to Manurewa as well, because I lived in Manurewa for 14 years. I grew up there, so it's an amazing community. So when you were going through, I was like, yep, that's them too, and Randwick as well. Okay, so first question for you from Leanne Edwida Summer. She says, Kia ora Summer, what were the most valuable lessons learned and what suggestions would you have for future planning or responses?
Yeah, that's a really good pātai, and it's something that we're challenging our system to date because, you know, all of a sudden when you work in a SIM structure, and I don't know if you, it's a crisis incident management structure, all the rules kind of fall away of, you know, business rules and stuff like that. We were able to get money out the door really quickly and really make really rapid decisions that enabled and empowered Māori providers, you know, partners, community to be a part of the solution. But, you know, when everything was over, we went straight back into the bureaucratic rules and systems and hoops that, you know, that are important for us as public servants, but, you know, we never brought that learning along. So that's one of the biggest learnings for me, is how quickly something can turn. And that is our job now, is, hey, we've done it before, let's find a safe way to unlock these resources to make sure that our communities and our providers are a part of the system. And again, there's no learning. Health promoters know it, the power of community action. It was more so, how do we lift the learning and make our system value that and acknowledge that and get resource and include them as part of a health promotion approach and a health solution.
Choice. I was going into my next question. Actually, that was a question from me. So you talked about, you know, the different levels, grassroots, community to regional to local, because as health promoters, we have the lens to look at those and try in some way to impact those. But when you're working in the rural area of Murupara with $3 in your budget, or you know, you're just trying to impact your community, what, if any, is there any advice you can give on how to break into that space? Because when you're talking about reorienting, sometimes, not all the time, but sometimes it can be a huge monster and quite a scary thing to do. But any advice for whānau around that?
Yeah, thank you for that question. I think we're still learning, and I don't say this is the only answer. We've got to test and learn and validate and make sure that our whānau are happy with that response. But I think that framework really helps us to think differently. And, you know, because, you know, if we think about the community of Murupara, lots of Māori there, but also if we think about that segmentation piece and really think around how our communities are segmented up into different cohorts. And when we go out into doing community action, so you're data-driven, so if we were to take childhood immunisations, we look at where's the lowest vaccination rate, then you go there, but then also you approach the community leaders and say, how does your community roll? Like, you know, please share with us, how does your community roll? How is the best way that we can partner with you and make have a community action response that nā koutou e tohua you know, so let them drive that. And, you know, so I think the first point for us is what we're learning is like doing the scan of where are the underserved populations, including the pockets that sometimes data doesn't pick up, and who are those community leaders, because they will tell you, oh, it's this street, it's, you know, this papakainga behind this marae, and then saying, well, how do they roll? Like, please, you know, share with us, and be like privileged that you're getting that level of intel from your kaumātua and your community leaders. Yeah, but again, we're still refining and learning as we go.
Yeah, that is every situation is different one. So yeah, that is a if you can get it right, it can be hugely impactful, but it takes a lot of you to all be on the same kaupapa. Last little question before we move on to our next speaker. For our non-Māori health providers, in terms of working with Māori communities, what's your advice for them who are looking to be supportive, looking to tautoko, but not sure how they kind of fit into that space?
Yeah, I mean, everything that I talked about is just health promotion best practice, eh? And then the kind of like kaupapa Māori bit and the cultural thing is just like leaning in onto your Māori leaders to test that that's the right way, or to give you some intel around what is the right way. So I think it's still really applying best practice health promotion in your thinking, but every layer, and then always thinking, what are we missing? What do we get? And then, you know, partnering with the community leaders and our Māori partners. I think I saw someone from the NHC here. You know, all of our Māori providers are open to doing anything that means that their communities will get served better. And just a kōrero to our non-Māori colleagues, no matter where a Māori person goes, they have a right to having, you know, really good quality, culturally safe care. And to receive information and health messaging and health education in a way that is meaningful and relevant to them. And also there is that kōrero that if you get your service design, your delivery, your health promotion, your anything right for an Indigenous person, it's going to suit and work for everybody that lives on that whenua. And you know, that's well evidenced. And you know, we do have that kōrero, what's right for Māori is what's good for Māori is good for everybody. So, but also saying that, I just want to mihi to all of our non-Māori colleagues in the sector that work really hard to address the inequities and apply te tiriti in their mahi.
Miharo, thank you, Summer. I'll give your waha a bit of a rest now. Don't forget, we're going to come back at the end for a little bit of a wrap up. But thank you for that, Summer Ngamihi. All right, we're going to go on to our next speaker now. So let me please introduce to you Vishal Rishi. He rangatira ia no te whenua o Inia. Vishal is originally from India, but has led collaborations in New Zealand's ethnic communities for over 20 years now. He's the director of TANI, the Asian Network Incorporated, which has become a well-recognized provider of Asian public health and social services in Aotearoa. He has extensive experience in public health and health promotion. He is also the chair of the Ethnic Health Collective Strategic Group and board member for the Commonwealth Study Conferences New Zealand chapter. Tēnā koe, Vishal.
Kia ora Mariana, tēnā koutou, tēnā tātou katoa, everyone. Kia ora, ko Vishal Rishi aho. No, as Mariana already mentioned, no Inia aho, migrated here 22 years ago, and ke Pukita Papa Tamaki Makaurau aho e noho ana. Tēnā koutou, tēnā tātou katoa. Assalamu alaikum, Sister Sadika, and Malo, Talafalawa, Ahanseo, Nihao, Namaste, and a warm, not really that warm here in Auckland, but it's a bit cloudy, but warm greetings to all of you. Thank you once again, Sione and the team, for giving us the opportunity to share our kōrero today. What I'm going to do, look, there are too many slides. I'm going to skip a lot of slides in between, but just to give you the flavor of the diversity, the richness of the broader Asian communities we work with. So I'm just a caution that end of the presentation, there won't be a one medicine or prescription given to you that, oh, wow, this is the way to work with the Asian communities. No, there is none. But I think it will give you the flavor and the layers which Sister Summer has just mentioned. We have to unpack the layers of our communities, needs, diversity, inclusion, and so on. So it will give you that sort of a lens to address the issues within the Asian community. So I'm going to share my screen. Hope it works now. I know now you're looking at the whole, my other slides as well, right?
We can see your other slides, but kei te pai.
Yeah. And it goes on. Slideshow. Sorry, we did try that. Oh yeah, that's here we go. Yep. Yep, can you see that now?
It's still on the same one.
Wonderful, good.
Oh, here we go.
Finally managed. Thank you, Mariana, for the help.
There you go. There you go. Your way, Vishal.
Kia, we are also known as TANI in the community. It's the abbreviation, the Asian Network Incorporated. And our vision is the Asian New Zealanders enjoy optimal quality of life and well-being in New Zealand. Sorry. Oh, yeah. So we are a pan-Asian health and social service provider working for the betterment of Asian communities and well-being. And we work towards empowering Asian communities and respond to their emerging health, well-being, and social needs. So we act as a bridge. You can see the beautiful Chinese bridge there between the mainstream service providers and the broader Asian communities. Of course, our commitment to Te Tiriti, it took us quite a few years in the beginning since we started in 2002 to understand the real meaning of being an Asian service provider with a hardly any money in hand or in the bank account, how we can make those commitments or adjustments, and how to understand. You know, it took us quite a lot of time to understand that, but I would say still after so many years we are learning, and we are on to this journey of learning together and our commitment to the treaty. So the Asian Network ensures that the principles of the treaty are reflected in whatever we do, which I think you are going to see in the other slides I'm going to present today. Partnership, participation, protection, and lots of collaborative work we have done. If I may ask, who are Asians in New Zealand? So it is like if you take out Europe, America, Pacific, the rest of them are Asians, probably, generally people say. But the official term which we used, the definition we used of Asians in New Zealand is Asian encompasses people from vast area of Japan in the east to Afghanistan in the west. And people, of course, self-identify Asian cultures and heritages. For example, when it comes to health, then the Fiji Indian population living in Pacific from last like 5th or 6th generation there, they consider themselves as Fiji, Indian, Pacific, but their risk of getting diabetes, CVD, and other health risks are the same as people coming from India or South Asia. So and same way people say a Chinese person migrated to New Zealand from South Africa or UK, for example, shall be considered as when it comes to health under Asian population. Asian population journey is quite vast. As you can see, the quick stats here, in 1986, we were only less than 2% of New Zealand population, but in 2013, it was close to 12%. So there was a nine-fold increase within the Asian population during 1986 to 2013. And currently, we are about sitting at 19% national population. But in Auckland region, we are nearly about 35%. So it's huge. It's growing very fast. Diversities, but the challenges the Asian population brings in with it is the richness, of course, the opportunity, yes, but at the same time, challenges with the diversity, because Asian populations, including Asian subgroups in terms of ethnicity, culture, language, religion, migration history, health beliefs, health systems they have migrated from are quite different. So it's quite a vast, a big, huge area to unpack, different layers to unpack. Out of all Asian communities, Chinese is the largest Asian subgroup, but very closely followed by the Indian, then followed by Filipino and Korean. And this trend is almost the same in every region in New Zealand. It's a very key point I need to make here is more than 80% of current Asian population in New Zealand is born overseas. Of course, there are lots of issues. I won't get into the challenges of Asian health, but I think a few of the challenges I've just mentioned here, considering the time restraint, to give you an idea, most of the Asian population, when they migrate to New Zealand, they are healthier population of the other lot of Asians who are not here. So which means they are screened, very well scanned before they get their permanent residence or the visas or the work visas. So which means they are pretty healthier condition clinically to come and arrive in New Zealand. But there are lots of studies already being proved that due to healthy immigrant effect, which means after their stay in New Zealand, say 6 to 7 years onwards, their health starts to deteriorate over the period of time. The more they stay, they get more ill or sick. And there are plenty of reasons for that. So Asian people have less access to health and social services in New Zealand because, as Summer also mentioned, health is not the priority when migrants go to any particular country. Health is not their priority because they believe, oh, they are already been scanned and now they need not to go to see the doctor, or they need not to enroll with any screening services, although they are free, but still they do not do that because they believe they have already been scanned and all the medical examinations have been conducted already. So this includes the primary healthcare enrollments, uptake of screening programs, and access to mental health services, age residential care, disability support services as well. So possible contributors to these disparities include stigmatization, language barriers, cultural attitudes and behaviors, understanding of New Zealand health system, because most of the Asian populations come from a very diverse public health system in our countries. Most of the Asian countries, whatever doctor says is yes, 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 okay, yeah, you are the key person, you know everything, so I need to follow your instructions. Same way, government does not go back to the communities for consultations, which is very common in New Zealand. And very common in New Zealand, what we have seen is they consult, but there's no outcome comes back to the communities. So the kind of distrust with the health system or any other system is also one of the factors which we are learning and hearing from the community, because they keep hearing but don't do anything about the things. So lots of consultations. Yes, we underpin all our delivery with the core health promotion model, Ottawa Charter. We advocate, enable, and mediate, contribute building healthy public policies, and also create supportive environments. And also health equity is center of our delivery, addressing various determinants of health, and the models. What we use is a different methodology to reach out to different Asian subgroup, to support, empower, and encourage participation from them. I will show you some examples in the next few slides. So these are the right across our programs, we apply Ottawa Charter principles. This is what we definitely believe in. Health promotion programs based on principles of engagement and empowerment offer real benefits, and that's where core of our work belongs to. So diversity, equity, and inclusion is our delivery lens. And these are some of the examples of our activities, what we do to enable, mediate, and encourage the Asian community to have better access to the public health systems here in New Zealand. So I won't go one by one into all of these, but I'll show you some pics. So that will give you enough idea about how we work. So this is just example of one of the Asian forums we have had recently, not recently, it's a few years ago, where we invite the speakers from different health agencies and Asian leaders to take part. These are some of our regular network meetings which we hold here in Tamaki Makaurau. And the beauty of these meetings are all the service providers, health service providers, as well as the decision makers, they do attend these meetings and meet with the community at the same time and learn about what are the interventions and what sort of designs may work better for the Asian community. And this is how we reach out to our communities. We have multiple ways, but I think this is one of the very best and very successful way of reaching out to Asian community in different languages, Korean, Mandarin, and English. These are the 3 languages newsletters we publish quarterly. It's 12-page newsletter. National newsletter goes to National Library. Any provider can come in and submit their articles to go into it. We don't talk about our programs in this newsletter. Only 1 page is dedicated to us, but the rest of the pages are dedicated to all the other service providers. So this is our collaborative way of working with the mainstream. We go out to various events in the community all the time in Hamilton and in Auckland. And promote health messages and servicing. I would like to share, I think last couple of years ago, in one of these events, we had a Auckland breast screening team with us on our stand, and they were shocked to see, including us, the 2 Asian women who were living there for more than 20 years in New Zealand were not even connected to the health system. So that was pretty shocking news for us as well as for the breast screen Aotearoa. And that was the time when we managed to convince them to get recruited, get that checked, and recruited them to the screening program. Since then, we found a lot of those such women are still here in New Zealand. And those 2 women are have introduced the same service to other women who were not connected as well. So it's just a beauty of working with the same culture, how you convince within, as we have seen what in Summer's presentation, some champions in the community can definitely make a big difference to make the access better. So, these are the health talks and seminars. Last year, we delivered more than 60 health talks across Auckland region. These are a few of the examples of different language health talks. And we are present in more than 35 localities in Auckland region. And we partner through Auckland Council, through Auckland Libraries. This is another way of working with the South Asian community on a very sensitive topic of family harm and disability. So what we did was we took one of the local artists and she had a full long paper on the wall. And as the people were talking about the SWOT, strength, weaknesses, opportunities within our communities to address that particular issue. So she was drawing everything. And by the end of the workshop of after 3 to 4 hours, we were having some sort of community-led solution for that particular locality. So these kind of initiatives are very close to my heart, and they have very good results of that particular locality where we work in. So this was another one where we use the similar methodology on family violence. Look at the strengths here on the left-hand side, moving on to the possible solutions and identified solution on the extreme right-hand side. So definitely, I always thank COVID because COVID has taught us many ways, alternative ways to engage with the Asian communities. Believe me, before COVID, we were not delivering our programs online, but since we started delivering our programs online, our outreach, community outreach was increased by threefold. So if previously we used to have 5,000 community organizations and individuals into a database, now we have 15K. So a lot of people coming from different areas, different rural areas, Asian communities coming from and attending our events and programs. We are still running mindfulness and yoga online every week. These are a few of the glimpses from our. Oh yes, cultural tours as a beautiful contributor to the inclusion and the holistic well-being. So people really enjoyed coming to these cultural tours. And especially guided cultural tours, which gives a kind of real meaning of going to Moanga. What was the significance of that Moanga for Maori? Which iwi was living there? What these plants, each and every plant on that Moanga has some meaning. A little bit of ditch has some meaning. They used to store food there. So lots of learning. And the people who you can see in these pictures have been living here for last 1 or 2 decades, but they never have gone on a guided tour like this before. So there was a very good learnings. And now whenever they visit that Moanga, they always remember and they feel inclusive, and also those stories they carry along with them, that learning, they can pass it on to their children. So very interesting. These are another, this is how we contribute to research and policy. We partner with majority of the research institutes in New Zealand, Massey University, AUT, University of Auckland, and Victoria University. So I will just quickly pass it on because I'm cautious of the time. This is another empowering women program. What we used to do, this program was as a result of some of the barriers our women were facing to attend lots of health screening programs or any other health information programs in the community we run. So, for example, if 25 or 30 women used to register, only 10 used to turn up. And then we gone back to those 15 who didn't come, who were unable to attend the program, to ask them what was the reason. The reason was they had only one car or one vehicle, or they don't know how to drive. They had to limited English. They can understand English, but they don't have confidence to go out and speak English. And also they don't know how to drive. So these 2-3 components we captured into one program and created one program for those women who were unable to come and attend the different activities and different programs in the community. So as we started this program, all the women who were not attending those particular workshops, they started to attend. And also not only that, but many women, after obtaining their driver's license, they were able to get the 20 hours or 30 hours jobs per week as well. So this is all related to our public health and health promotion work and addressing the determinants of health, actually the things that matter to their lives. And slowly they have started to access the public health and core health promotion activities. This is one of the beautiful examples of our collaborative work with 4 other providers, one Pacifica, Phono, and HealthWest, a Māori provider, CNSST, East Asian provider, and we were handling the South Asian component for this particular program. It's currently every year, 100 women graduate through this Healthy Babies, Healthy Futures program. Oh, take-home messages, very important for all of us. As I mentioned in the beginning, that there is no one particular tablet or a pill we can give or suggest, which may suit to all broader Asian communities. I know this cartoon is not appropriate. They're taking the home, but it meant something else. So critical commitments to build cultural responsiveness in health promotion is respecting that the personal cultural background can affect their health behavior, health decisions, and how they manage their health. Being open to new ideas, accepting that the other culture and ideas might be different from yours or the decision makers, knowledge of prevalence of disease and risks, and ability to identify risk factors among specific groups without stereotyping them. And ability to identify risk factors among specific groups and communicating the same without stereotyping again, valuing the role of the cultural experts or the people living in the particular community or the elders of that community. There are lots of examples we can give when we started the Healthy Babies, Healthy Futures program. In Indian culture or Asian culture, women, once they give birth, they shouldn't be asked to take shower, stay away. But here in the hospital settings, as soon as a woman gives birth, the nurses encourage them to just go take shower. Not only this, but the grandmoms or the extended family who are sitting next to them, they start feeding them with lots of saturated fat, sugar, so that mom gets that strength. But that is not applicable when we talk about health and health promotion setting. So that is why the cultural appropriateness and the balance we have to make, and that is where we come into the picture and replace those unhealthy elements within the same diet with the healthier elements with our nutritionist. Health promotion staff in all organizations are provided training and professional development to enhance their cultural responsiveness. We don't want all the health promotion staff in the mainstream to be equipped with all the cultural needs, but at least the basic needs which should be must-do needs, must-do things. Practical training around unconscious cultural biases and how to manage these. Last but not the least, setting a safe and supportive learning environment for all, providing the health promotion in a simple messaging and ideally in different languages, developing resource material with narration, with more visuals rather than the more text. So most of the Asian population would like to see more pictures. Valuing everyone's identity, background, and experience, and lived experience. Don't underestimate, please, the lived experience of the other Asian communities. These are few of our partners we have worked with in the past. Just about to finish. And here we are. We'd like to acknowledge all of you here today, listening us, and past and current board members, Ministry of Health, Ministry of Social Development, and all others there. And here you can contact us. Sorry, there are too many ways to contact us, so choose one or the other way, so we will be in touch with you. Kia ora koutou, open to questions, and I will just stop sharing this so that I can see who are there.
Ka pai. Thank you, Vishal. Wow, I feel like I just got schooled up in that 20 minutes. I'm going to be honest, my knowledge around Asian health promotion is quite limited. So that was really, really eye-opening for me. So thank you so much, Vishal. I'm going to ask you for your PowerPoint presentation after this, if that's
sure.
okay. And I'm sure some of our attendees would like to have a look at that as well. We do have a question from the audience.
Yeah.
I'm just going to have a look. So this is from Emma Phillip. Oh, this is from Emma Phillip. And she asked, when you hold community meetings and health talks or seminars, what type of topics do you cover and where do you source your guest speakers from?
Very good question. We source the guest speakers from the local, if we are in Henderson, for example, we source our speaker from the local Henderson area. There are lots of organizations who are generally very keen to engage with the Asian communities. And also with in the end of every seminar, we have an evaluation form. And on that evaluation form, that particular locality Asian community, they fill up what sort of topics they would like to hear in the next seminar. So this is what we evaluate and see, okay, most of the people are interested in kidney health, or they might be interested in diabetes. They might be interested in some other health topic. So this is how we take decisions for different localities. And we resource all the speakers from mainstream, our ethnic health providers, or anyone else. Anyone can raise their hand up, and we will be more than happy to invite you for one of them.
Awesome, thank you. And one last question from me. I'm looking at my own cultural competency, and I'm sure others will be thinking it too, in terms of our plethora of Asian communities. Does TANI offer training around that sort of stuff, or do you know where we can go for just for the basics? Other than going to our communities.
Look, there
directly.
was a module developed for called communities, culturally and linguistically diverse communities by Vatimata. Solim developed that tool, but I think that tool needs some revision because it was quite outdated. But I think we'll be more than happy to run some workshops around that, about cultural needs and whatever we have presented, take in and take one by one step further. We can do that, but we haven't done that formally yet with the organizations, but we can still organize that if anyone is requiring that one. Yeah.
Excellent. Yeah, it might be a corridor with yourself in Sione too. I think that's something, and a lot of even outside of Auckland and Wellington, a lot of communities.
Oh yeah, we did few workshops, Sione, if you remember, in Christchurch and a couple of other places in the past. Yeah, it's a long time now. Yeah.
Okay, the future project, future project.
Yeah.
All right, thank you, Vishal. We're going to move on to our final speaker before we come back at the end for our gallery. So thank you, Vishal. We're now going to move on to our final speaker for today, which is Sione Tuitahi. So, Sione, he āmorangi rawa a Sione no ngā motu o Tonga. Sione is the Executive Director here at Health Promotion Forum of New Zealand. He's been at the helm of HPF for over 10 years now. In 2019, Sione was honoured with the Public Health Champion Award from Public Health Association New Zealand. He is a member of the global think tank with UNICEF. He assists in many academic courses related to health promotion, and he is also the global president of the International Union for Health Promotion and Education. So tēnā koe tōku tuakana e Sione. Kia ora.
Kia ora, Mariana. Can you hear me well?
Perfectly.
Great. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Ko Sione tuitahi hoku hingoa, ko e tumuaki o e Health Promotion Forum of New Zealand. It's an honor to be here this morning and to join Sama and Vishal sharing some thoughts on this very important, very timely topic of culturally responsive health promotion approaches in Aotearoa. You'll be happy to know I only have 2 points to make, and that's two questions. And the first one is, what is a culturally responsive health promotion approach in today's world, and especially here in Aotearoa and New Zealand? There have been many transformational changes, politically, culturally, economically, in health and in other sectors, global challenges that we are facing at a global level affecting us. And it requires us to go back and rethink and reimagine the tools that we have and the values and the philosophy of health promotion over the last 3 decades or so. So I would like to address that first question, but also ask the second question, looking into our own practices as the Health Promotion Forum of New Zealand, and see how culturally responsive our services is. And hopefully there are some lessons there to share and to learn from, but also some improvements that you can tell us to work on. And so the first question is, what is a culturally appropriate health promotion approach in this year of 2024, like what the speakers before me have shared? And I also acknowledge not only Vishal, but Sama with her leadership in our public service, especially the National Public Health Service within the Ministry of Health. And we need to bring our baskets of knowledge together and learn together. It's your rau and my rau, my basket of food and your basket of food, and we will have a wonderful feast. But back to my definition of what is a culturally health promotion approach in today's world. As has been said, it's not only appropriate culturally, but more importantly, it enhances the health and well-being of the people that you are serving, whether it's your whānau, hapu, iwi, an ethnic group, as in the case, or pan-ethnic groups in the case of Vishal, cultural groups, interest groups, whole communities, our nation. And equally important, our whole one human family and our one common home, planet Earth, and make sure that no one is left behind. And when I say left behind, I'm not just talking about human beings, but also other beings, plants and animals, so on and so forth, because we are so interconnected, as has been mentioned. If there's a big lesson to learn from COVID-19 and many floods that we've experienced, not only here in Aotearoa, but also around the world, we are one ecosystem, and one part is affected, it will affect the rest. So we need to work together. And then come the sub-question of what is health and well-being, and how do we measure, how do we measure our progressing of the health and well-being of communities? Well, there have been quite a few tools over the years, from the national level up to the global level, have been shared. We don't have to go back to the drawing board and start from square one. We can draw, as Sama and Vishal have demonstrated in their services and their leadership and their thinking, that we are rich already. it's about two things: how to reimagine those tools today, and how to take it off from the shelf and apply them again. We go back to Te Whare Tapafa, Mason Dury's general health model for Maori, applicable across the board. Our body, our mind, our spirit, our wairua, and the whole whānau, of course. Or we move back a decade, forward to 1999, when he presented at one of our Health Promotion Forum's symposium, Te Pae Mahotonga. Is it about now making sure that Maori access Te A Maori? And how about the protection of the environment, Waiora? Our healthy lifestyles. There are a lot of social hazards, in our communities today. We are still dealing with quite a few of them, as we have done many decades back. And our participation in society, not only Maori, but other groups, the more recent migrant groups like the Asian communities. How about our leadership? We need to make sure that our leadership is sound, is effective, is courageous, but also ethical and spiritual, not only at the national level, but also at the global level. There's also whānau, a whole policy, a whole package on its own, with the tools that have been developed over the years and is still being applied across the board, not only with the direction of the Whatuora, but also among communities across the countries, not only Maori, but also Pacific and other cultural ethnic groups. Or we move forward after Te Pae Mahotonga in 1999, 20 years later, Mason Dury launched Matariki, which is a combination of the guiding stars of Te Pae Mahotonga and the stars of Matariki. He talked about this as a new framework for health promotion at the World Conference on Health Promotion that was co-organized by the Health Promotion Forum and the International Union for Health Promotion and Education, the one that I'm the current president of. For the Pacific communities, equally applicable to other communities, you have Whanuaora, that deals with physical, mental, spiritual, socioeconomic, cultural, and ecological well-being. Or more recently, the Geneva Charter for Well-being that was launched in 2021. Those are, I've listed there the 5 priority areas that we need to focus on. Sama and Vishal touch on the Ottawa Charter, which is still a strong linchpin of health promotion over the last 40 years. And when you look back, it's still relevant to today. You see social justice and equity, but also the concern for the environment, stable ecosystem, sustainable resources. And I'd like to point out that the Health Promotion Forum, being conscious of the impact of the global changes that are happening there, and the need for us to input from Aotearoa, by trailblazing that pathway, we were able to contribute to international tools like the Geneva Charter for Well-being. If you read closely the Geneva Charter for Well-being, it's the first time where Indigenous knowledge is acknowledged, and equally Indigenous leadership, and an expansion of our understanding of well-being to cover ecological well-being as well as spiritual well-being and social well-being. So these are tools that we can look back at. But how do you make your organization or yourself be more culturally responsive? And firstly, you start with the organization. Make sure that it's your vision, your values, your goals, your policies, your capacity, your resources, and your practice. You have to walk our talk. And your outcomes are culturally responsive, meaning that you enhance, you progress the health and well-being of any community that you serve. If you transform your organization, then you, the health promoter, will become more fully culturally responsive. I've seen over the decades the bottlenecks and the inability of the practitioner to transform communities, not because of the lack of capability and capacity, but the lack of institutional change that needs to happen within providers within services, not only in the public health sector, but also in the civil society and within NGOs and communities. And this is a challenge that we share, not only nationally in New Zealand, but also at a global level. So what is the best way to move forward to be more culturally responsive? One way is to be more proactive, rather than being reactive. So the best way for me is to be proactive and not to wait for challenges and changes to come and overtake you. Rather, that you descend the horizon and manage change and be the change that you want to see. And our practice to be transformative and reflective. There are lots of lessons, as Vishal and Sama have shared, lots of lessons that we have learned from COVID-19 and other global challenges. And those lessons are enough to transform our thinking, transform our values, and transform our institutions and our practices as well. And it is actually happening. And we need to collaborate not only internally, we work as a team, we are an ecosystem within and outside the organization. We are all in this together. So here are some details of what I mean by the best way is the proactive way. Transform your organization. Make sure that you also transform your own personal and professional values as a practitioner. Your values, your qualities, your practices, your attributes. And as has been mentioned already, to be grounded on Te Tiriti. Because in addition to being the foundation document of our nation, it also provides for the well-being and equity in a culturally responsive ways. Te Tiriti, if you study closely, provides not only justice, but also spaces for all cultures and languages to survive, thrive, and flourish. It also takes care of Mother Nature. So I hope I have addressed to some degree the first question. Let me look inward, my own practice and my small but agile team, the Health Promotion Forum of New Zealand. Firstly, our constitution demands us, requires us to cater for all. And so at the governance level, there is a partnership configuration and approach and belief that 50% of the members of the board are Maori, and the other 50 are other ethnic groups in the country, Pākehā, Asian, Pacific, and others. And in the management team, there you see also not only diversity of ethnicity, but also diversity of skills, capabilities, and also of leadership and various ways of approaching our task. We are a small but very diverse team. And our plan, our activities, and our outcomes are geared towards, guided by Te Tiriti Waitangi, and also the international tools that I mentioned before, from the Ottawa Charter to the Geneva Charter of Wellbeing, to make sure that we deliver the outcomes that the specific sectors of our workforce that we co-learn together and co-lead together, that we are able to deliver what they require and demand of us. As I mentioned before, what is happening at the global level impacts directly on the local level. And so for more than 10 years now, we have been working at the global level. We were able to contribute Indigenous leadership and Indigenous knowledge to the work of the International Union Health Promotion Forum. And I have the honor of being elected by my colleagues across the world to be the president of IUHPE. And through that, I've been able also to work with the leadership of the Health Promotion Department at the World Health Organization and contribute to shaping the Geneva Charter for Wellbeing, as I have mentioned before. We do all these things at a global level because what happens at global level impacts directly at the local level. And the example of that here at the Health Promotion Forum, health promotion is defined as based on the combination of Te Tiriti and the Ottawa Charter and all the other charters that have been developed by the World Health Organization. And we are fortunate that we have been able to do this work. And one of the outcomes that we have come out of, gained out of that international collaboration is for the Health Promotion Forum of New Zealand to be a national accreditation organization. Simply, it means that we are now going to be able to formally recognize health promoters and the health promotion profession as a formal professional field. IUHPE has developed a global system, and it means that health promoters can be assessed, you can be registered, and your competencies is formally recognized. And here in Aotearoa, New Zealand, we will start that this year, in the second half of the year. But back to the importance of transforming ourselves to be culturally responsive in your thinking, in your planning, and in your practice, and you walk your talk. Align your values, your goals, and your vision, build your capacity, and make sure that you co-lead, you contribute with professional and ethical courage. And we say with humility, but at the same time, we are assertive to the cause of justice, equity, and well-being. And as I have already mentioned, it is not enough just to provide a service to address the social determinants of health. We need to think about the well-being of our ecology, the well-being of Mother Nature. And so our approach today should be eco-social. We need to be conscious of the polycrisis, the wars, the geopolitical conflicts, the economic systems that are ruining our planet and our life as well as humanity. And we need to make sure that we take all these challenges in considerations and work together as a one strong health promotion workforce, and also as a collective movement, working together as a sector, as part of the broader health sector. And so if you ask me, where do you start? Start where you are today. It's a long, challenging journey, but it's very rewarding. And leave some legacies for your mokopuna, because you are borrowing from their future. And remember, as I said before, we are into a significant global paradigm shift, and we need to revisit our values, our practices. And when we have the system up, be prepared to register as a health promoter.